You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 25th, 2020. This week, COVID, guidelines run amok, beta blockers, and academic overreach. As far as COVID, I'm just going to say it is still bad, really bad. Every time I see pictures from last year, I feel a wave of sadness. I miss seeing my colleagues. First topic today is about sports participation after COVID-19 infection. The American Academy of Pediatrics released guidance on return to sport after COVID-19. This is a well-meaning document, but it is a mess, and it is potentially dangerous to youngers. There are specific lessons and general ones, but first, I want to say that sport is a hobby, perhaps even addiction of mine, and I have made every dumb mistake one can make returning to sport activity. Now some basics. SARS-CoV-2 is a virus. Viruses create inflammation. Inflammation is how we survive as a species. Without inflammation, we would have no defense against pathogens. Sometimes the needed inflammation affects the heart. This is stochastic, meaning it's a random event that may be analyzed statistically but cannot be predicted precisely. An example of a stochastic event. A cardiologist is exposed to a lifetime of radiation, and more radiation exposure associates with more cancer risk. But you cannot know precisely your personal risk. So the most common cause of myocarditis is viral infection, and these are not usually subtle. People with myocarditis appear sick, with chest pain, arrhythmia, often ECG changes. You can measure blood markers of inflammation like CRP or ESR. Troponin assays these days are so darn sensitive that even a minimal amount of heart irritation will cause the cardiac enzyme to be elevated. If a person has active myocarditis from any virus, it is a bad idea to stress the heart by exercising. In the same way you don't walk on a broken leg, you should rest your heart when it's inflamed. So in weeks past, I have discussed the contentious issue of COVID-19 and myocarditis, and I will not rehash the entire discussion. In brief, some of the short story is this. As of yesterday, there have been 32 million cases of COVID. If the incidence of myocarditis from COVID-19 is even 0.01%, there would be 3,000 cases of myocarditis. Now consider social media. Go back to the pre-COVID times first. Did any cases of myocarditis from Coxsackie or RSV or adenovirus or influenza or the hundreds of other pathogens that can inflame the heart go viral? Did they get to the Washington Post or New York Times or ESPN? No, but now nearly any case of heart inflammation from COVID-19 is going to be amplified. But my friends, there is no compelling evidence, right now at least, that SARS-CoV-2 is any more likely than other viruses to cause myocarditis, especially in young people who seem mostly spared. The JAMA Cardiology paper that stirred most of this excitement with its 700,000 page views has now been corrected, and if you compare the MRI abnormalities to risk factor matched controls, there is no significant difference. What's more, patients in that series who were thought to have inflammation of their heart, seen on MR scans, had normal levels of CRP and troponin. In the most recent research letter, again in JAMA Cardiology from the Ohio State Group on 26 competitive athletes, which was hyped initially, but once the paper was published, found the following, and I quote, "There were no diagnostic SDT changes on ECG, and ventricular volumes and function were within the normal range in all athletes by echo and CMR imaging. No athlete had elevated serum levels of troponin I. It could just stop there. I wished it did. So what was the hubbub? Well, the hubbub was 4 athletes were thought to have myocarditis by T2 signal and non-ischemic late gadolinium enhancement, LGE. The problem is that recent studies have shown that endurance athletes can have LGE. And who knows what a T2 signal means prognostically in athletes. So in sum, we haven't had adequate time to study this virus. But the statement in the American Academy of Pediatrics document reads, quote, because of the growing literature about the relationship between COVID-19 and myocarditis, end quote. That has no basis in science. Remember, my friends, professional societies are supposed to be pillars of science-based communication. So you might wonder, why am I going on about this? What are the specific issues? Well, my friend Venk Murthy, an academic cardiologist at the University of Michigan and a cardiac imaging expert, has a great thread on Twitter on this. I will link to it. The specific issues are the business about the recommendations from the Academy of Pediatrics. First, they recommend for youngsters who have had very serious infections, needing things like ventilators, they should be treated as if they have myocarditis and sit out of exercise for 3 to 6 months. So, why 3 months or 6 months? What if they are recovered clinically? What if they have normal enzymes and an ECG at 6 weeks? Why do they need more testing? What is the kid to do for the remaining weeks to months? The second recommendation is kids with moderate disease need to be asymptomatic for 14 days and obtain a primary care provider clearance, including an ECG, before return to exercise. Dr. Murthy asks, what is moderate disease? The writers hint that prolonged fever is one predictor. Well, I would ask, what the heck does prolonged mean? This is nonsense. Here is what will happen. Schools or organizations will make up rules. Kids who want to play may hide their symptoms, thus increasing the risk of transmitting infection. And then there is perhaps the worst recommendation. This is for all children and adolescents with exposure to SARS-CoV-2, regardless of symptoms. They require a minimum 14-day resting period and must be asymptomatic for more than 14 days before returning to sport. My gosh, if you are an American who leaves his or her house, you are likely exposed to this virus. And again, why 14 days of no sport? How is this even enforceable? What's more, as Dr. Murthy writes, there are all sorts of exposures, some high risk based on duration and proximity, and some low risk, but they will all be considered exposures. Now you know what risk-averse coaches in schools will do. I don't want to downplay COVID-19. We should all do the smart things. We know the smart things, which I won't repeat. But making a guideline like this is hazardous because it promotes fear, and fear shreds good decision-making. As Ivan Illich wrote, it creates a social iatrogenesis in which people fear lurking diseases. Fear plus a risk-averse culture will expose young people to all manner of harms from cascades of testing. Illich called this clinical iatrogenesis. I have first-hand knowledge of a case in which a computer reading of an unnecessary ECG nearly led to disqualification from sport and unnecessary test in a young person. The computer reading was totally wrong. Now to the general point about guidelines. The famous Eric Prostowski once told me that in areas of vast uncertainty, guideline writers should resist the urge. They should refrain from writing anything. That would allow thinking people, to use their judgment. Now, two of my favorite follows on Twitter, Dr. Raj Mehta and Dr. Richard Lehman, penned a brilliant editorial on uncertainty. This was in JAMA Internal Medicine. It was recent, and I'll link to it. They have a line in there that is pure gold. Quote, evidence-based medicine guidelines should look like half-drawn maps, indicating the good roads, but equally importantly, showing where there are no good roads. In COVID-19, there are a handful of good roads. Social distancing, for example. But there are far more areas where there are no good roads. Authorities would engender more trust if they just admitted to that. Okay, so next topic, are beta blockers beneficial after myocardial infarction? And I know that seems like a nutty question. Of course they are. Like every guideline everywhere says so. My EHR says so. My chart auditors say so. My pay for performance measures say so. Well, I have a slide I show in my evidence-based medicine talks I want to describe to you. The slide shows three things. The beta blocker post-MI trials that undergird the evidence were done in 1975 through 1987. That was when we treated MI with bed rest and morphine and Swan-Ganz catheters. Adrenergic blockade was really important then. The average length of these trials was 1 to 3 years, and the average age of patients in these trials was 55 to 60. Those are pretty old trials. Well, a Danish observational study presented at ESC and smartly covered by journalist Bruce Jansen suggests such data may be obsolete in an era when blockages are vanquished by on-call cath lab teams. Anders Holt presented his observational study. This was of stable post-MI patients for greater than 3 months, and he used the beautiful Danish registries where all citizens have a unique number. And the study ran from 2003 to 2018, included all patients hospitalized for MI. And the comparison was of patients who had no beta blocker, 5,400 of them, and beta blocker treated patients, 24,000 of them. They determined beta blocker therapy because of a redeemed prescription. The mean age of these patients was 62. Previously treated patients with beta blocker were excluded, and patients with heart failure were also excluded. It was a 90-day blanking period. It only included patients treated with statins and aspirin. And the follow-up was about 3 years. And of course, this is a non-randomized comparison, and they used regression techniques in adjusting for confounders. Their endpoints were hard endpoints, MI, CV death, and a composite of cardiac events. They also noted an important trend, actually. The number of patients that were not treated on beta blocker have increased over the years. The bottom line is that they found no difference in any cardiac events. The absolute risk of all-cause death, no difference. Let me repeat. There were no difference in cardiac events in the beta blocker or non-beta blocker treated patients after MI. That's a provocative finding, so the authors did some other supplemental analyses to give them confidence in whether this was true data. One of these is called a positive exposure analysis. And so what they do is they look at statins association. And indeed, it showed that patients treated with statins had fewer events, which you'd expect, which increases the confidence that the data are real. They also did a negative exposure analysis, and they looked at the effect of beta blocker on pneumonia and found no association, which also you'd expect. So again, increasing confidence that the associations are real. Of course, this is observational data, and Dr. Holt was very clear about the limitations, for instance, selection bias, and they don't know the reason why 5,000 patients did not get beta blocker. Nonetheless, given the large size of this, if there was an effect, I suspect it would be a very small effect. So there are things that this data should and should not do. They should not be used to say beta blockers do not work post-MI anymore. But this data should stimulate us to consider a proper RCT to evaluate this question. At minimum, we could consider a study looking at discontinuation of beta blocker after 3 or 6 months in non-heart failure post-MI patients. Fortunately, Professor Dan Attar from Oslo University is leading a 10,000 patient strong RCT of beta blockers versus no beta blockers in post-MI patients. I will link to the clinicaltrials.gov site of the beta MI study. This data should also serve to remind us that medicine changes. As medicine advances, things proven beneficial in the past may no longer be so. Examples of this include aspirin for primary prevention. Aspirin used to be good for primary prevention. Studies showed that it reduced events, but 3 trials in 2018 show no net benefit to aspirin. This is likely because of declines in cardiac events over time, so-called temporal decreases. Then there's the landmark Danish trial, which showed no ICD benefit in patients with non-ischemic cardiomyopathy. This is in comparison to the 20-year-old SCUD-HEP trial that did show benefit. Again, this is probably because medical therapy reduces event rates, and now the ratio of sudden death to all-cause death is lower. Medicine changes. Next topic is underdosing of direct-acting oral anticoagulation in patients with AFib, DOACs. Is this smart or not? Now, you know the story. A patient is older or frail, has kidney function right above that cutoff for low-dose DOACs. On paper, the patient should receive the higher dose, but your gut, your clinical instinct says go with the lower dose. Well, a paper published in JACC from the Garfield Registry looked at effect on mortality, stroke, and bleeding based on DOAC dosing. The Garfield Registry is a prospective registry in 35 countries looking at new onset AFib cases. And this study was followed for up to 2 years. The Garfield Registry has nearly 35,000 patients, and this study considered 10,000 of these patients who received a DOAC. Now, most, or about 3/4 of these 10,000 patients received the standard DOAC dose, and about 1/4 were underdosed. Only 4% received an overdosing. So we'll focus on the normal dosing versus underdosing of DOAC, because that's the main clinical question. Underdosing associated with a higher risk of death, 1.25 was the hazard ratio. But, this is important, the excess deaths were heart failure and MI. Underdosing of DOACs did not associate with an increase in stroke rate. Underdosing did associate with less bleeding, which you'd expect. My comments on this study are that it is an important study because it teaches really vital lessons about evidence translation. Let's start with the author's second sentence in the discussion. Quote, use of non-recommended doses of DOACs had an impact on outcomes. No, my friends, that is wrong. I would correct that sentence and say, use of non-recommended doses of DOACs had an association with outcomes. Remember, this is an observational study, and there are surely reasons that doctors throughout the 35 countries decided to use lower dose DOACs. Now, journalist Steve Stiles quoted the PI, Dr. John Cam, as saying, underdosing is not just a little problem, it's a very big problem. Then Dr. Cam said this, so I think there's some confusion, a lot of caution that physicians use with anticoagulants, and they often forget that the purpose of the anticoagulant is to prevent strokes and adverse outcomes, such as mortality. But by reducing the dose, they expose their patients to these other major cardiovascular events. Cam then triples down on the confounded data and says, quote, it might also be argued that a physician who fails to treat a patient adequately in one arena may also be failing to treat the patient well in other aspects of their care. Now, my friend and colleague, Dr. Gerald Nacarelli, wrote the editorial, and he largely agreed with this sentiment. He closed with the sentence, underdosing of a DOAC may break the Hippocratic Oath. Now, I respect Drs. Cam and Nacarelli immensely. I really do, but I strongly disagree with their comments. This study can't say any of that. If you're going to posit that underdosing of DOACs led to worse outcomes, it had better be in higher strokes, not heart failure and MI. And boom, in this study, underdosing was not associated with a higher stroke rate. The fact that underdosing associated with higher MIs and heart failure and overall death tells you one thing. Doctors decided to use lower doses in sicker patients. Sicker patients have more MIs and heart failure and death. Now, this isn't just me positing this. Similar findings were also noted in Orbit AF, another observational registry study. That study also found that non-recommended doses of DOAC associated with a higher risk of death and CV hospitalizations. Same deal. Sicker patients get lower doses. Look at the randomized controlled trials. In the original Engage AF edoxaban trial, 1/3 of the patients were deliberately and blindly underdosed. That was the 30 to 15 milligram group. And the mortality was significantly lower than on warfarin. The p-value was 0.006. Go look at Table 2 in that trial. Then there was the most recent Elder Care AF study in which very elderly Japanese patients with AF received once daily 15 milligram dose of edoxaban, and it was found superior to placebo in stroke and did not result in an increase in bleeding. Look, I am all about correct dosing of any drug, but I push back hard on using confounded observational data like this to pile on against physician judgment. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, it really helps if you could take the time to give us a rating, write a review, tell a friend. These things help others find us. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.